Hey Sonu, how are you? Hi Sanj, how are you?
Hey Avi, hey Sonu buddy, you doing all right? Good to
Yeah,
see you.
you? It's good to see you.
Thanks for putting this together. This should be exciting.
Yeah, thanks for participating. Really look forward to your talk.
Oh yeah, no worries whatsoever.
Yeah.
Should we just try and uh,
Hello,
sh
everyone.
share everything? Hey
Hello,
PC,
how are
Can you
you?
hear- Okay, hi, you guys. Sonyu and Avi, right? I'm
Yes.
PCO. And yeah, Shane. Great to
hey
see you.
PC, good to see you.
Yeah, nice. So
Hello,
you are
hello.
studying.
Hello. Hi Jeffrey, how are you? Thanks for joining
Good,
us.
good.
Yeah,
My
okay.
pleasure, actually.
Um,
Hi, Sanji.
Hey Jeff, it looks like you're in a recording studio, huh?
No, this is just a wallpaper.
Yeah.
Sanj, in response to your point, yes, please go ahead and test your slides.
Okay.
Yeah, I'm the first speaker. Maybe I test a bit my slide first. Can I do
Yeah,
those?
See.
yes, please.
Let me see. Okay. Can you see my slide?
Yes, we see your slides.
I move on a little bit. Can you see the progression of slide?
Yes, we do. We see your video nicely as well.
Okay. Then I think it should be fine. Thank
Okay.
you very much. Very much. Great.
I can quickly share as well, just like PC.
Sanj, are you at AAHS?
I got back last night.
Oh, okay.
Yes. Okay. So let me just do you see this okay?
Yes, we do.
Yes.
I'm just going to put a video very quickly, see if this works. Do you see that?
Yes.
Yes, we see that.
Looks
Okay.
great.
All right. Thank you.
Thanks. Illy, quick question. We have the two people giving videos, right? I think. As for
Yeah, we have Greg Bain and Toshi
Yeah.
Nakamura. So
Yeah.
Ilya, you can play those videos, right?
Yes. You want me to see if
Okay.
I can have that work now too?
Yes, please.
Okay. Here is the first one. So did everyone see this?
Yes.
Yes.
Okay.
Great place to be involved in this symposium.
Can you hear everything too?
Maybe a little
This-
higher.
Yeah, the sound's a little soft.
Yeah, not so well.
Yeah.
This presentation is on the future of wrist arthroscopy.
That change anything or no?
That's better. But can you make it a little bit louder? Or is that
I'm
the
not
maximum?
I think that might be the maximum.
Okay. Can you test the other one as well?
Yes.
Good afternoon. Good morning.
Just only sound.
And here is the other one.
Good afternoon. Good morning.
Everybody hear everything too?
The sound is a bit choppy.
I don't know if it's the video itself or
Radio scope is not suitable. The viewing data. Then you can also see
does it still sound that way?
Yeah.
Yeah, it's a little bit choppy.
Yeah.
Hmm.
Did everybody have a chance to check their slides? Dr. Koo, did you have a chance to? I think you're muted.
Try to share my screen. Okay.
Yes, please.
Can you see my screen?
Yes, we do.
Okay. And the video is okay?
Yes.
Yes, it looks good.
Okay, good. Hi, Andrew.
And so we are just waiting Jeff, I believe.
Yes.
Hello, guys.
Hi, Andrew. How are you?
Hi, fine. Hello, everybody.
Good to
Nice
see
to-
you.
Hi,
Andrew.
how are you doing?
Good. Hi, Sanj. PC. Hi, Tonu.
Hi, how are you doing, Andrew?
Nice to meet all of you here.
Yeah, no, thanks for everybody for taking time off and at
all right.
whatever time that you guys are at.
No problem. Oh, by the way, PC and Harvey, happy Chinese New Year.
Oh, happy Chinese New Year.
Jeff,
Yes.
Jeff. Happy Chinese New Year to you. We're in the midst of our New Year celebration.
What is it?
So-
The year of the
Dragon.
Dragon. Yeah, it's a good year. Yeah. So Harvey, do you actually celebrate the Chinese New Year in your hometown now?
I do. My wife actually had did a dinner for Tuan Yen Fan like the day
Oh.
before.
Very good, very good.
Yeah, but nobody celebrates it in my town, so we just had that and that's it.
Family celebration is important.
Yeah, exactly.
Great. Yeah.
Excellent. Well, while we're waiting for Jeff, I think basically I'll introduce Harvey and Andrew here, and then you both will or you can decide, Harvey, introduce the different speakers all in the beginning or as they go along through their different talks, and then at the end we'll have question and answer if we have some time, and then I'll just conclude at the very last minute just to sort of just to go on for the webinar series. The only thing I ask is that when when anybody else is talking to everybody, just make their screens black so only the speaker is visible. That's the only thing. So if you're talking and if there's group questions, definitely have your speakers on, but that way, just the audience is focused on the speaker, and that's pretty much it. Otherwise, everything else is pretty standard. You guys have all been through multiple webinars throughout the last few years, I'm quite sure. So this is not your first rodeo.
So I talked about this with Andrew, and I have just a few slides to share, and then after that I'll turn it over to Andrew, who will introduce the Asian speakers. I'll introduce the American speakers, and I think we talked about it. We're going to do 3 talks and then have a Q&A, and then do 3 talks and another Q&A. So I'm just going to show my slides, just pretty basic stuff.
Yeah.
Do you see my slides? So
very good.
Yes.
yeah, so I'm just going to talk about the program a little bit, and then basically what you talked about, Sonu, just about some housekeeping matters, and then I'll turn it over to Andrew to introduce PC as the first speaker.
Thank you. Yeah. So it must be the first collaboration between the APWA and also AAHS, right?
Yeah, this is the
Yes.
first collaboration. Yes.
Very important, and very meaningful. Thank you
Yes.
for all your collaboration work and hard work to make it happen. Thank you very much.
We're
Thank
going to
you so
highlight
much.
that anyway, PC. Yeah, we're going to highlight that. Yeah.
congratulations.
This is going to be
Yeah.
great. Very excited. I think I think this is like the essence of what we're trying to do, is have more collaboration with the hand association with all the different societies, and this is an important one that especially Harvey is really forging ahead trying to make this happen. So I think Harvey definitely did the legwork of this. So thanks, Harvey.
Yeah, of course, you're welcome, Sonu. It's always good to do collaborative webinars, and Andrew really reached out to all the APWA speakers and brought everybody together. And again, thank you so much, for taking the time on the Saturday to come and speak to people.
Thank you.
fantastic opportunity for both societies and associations. Certainly looking forward to more collaboration with AAHS in the future. Definitely.
Definitely.
Yeah. Well, when was the AAHS meeting held this year? Was it being held already? It usually held in June, right? In July.
The
January.
AAHS was in January in
Yeah,
the
yeah.
Bahamas.
Oh, in Bahamas. Oh, this time it's
Yes.
Bahamas again. Oh, I
Yes.
went there once before, when when Mark Perez was the president. Yeah, I went there once.
Okay.
In a very big hotel. Yeah, there's a very, very big one. Yes.
Yes. Very expensive also.
Yeah, I think so. Good.
Andrew, you're going to be sharing us some slides of your latest food reviews, huh? I like reading those. That takes a lot of effort.
Food review.
We can have a separate a webinar on that.
Yeah, why
Well-
not? Why don't always necessary to be medical related? I think that'd be welcomed by all the members.
Yeah, I will sign
You
up.
got-
Andrew,
Yeah.
you're just in the US as well, right? Like 2 or 3 weeks ago.
Yeah,
or something.
about 1.5 weeks ago. Yes, correct. I was in New York.
Okay.
Yeah.
Yeah, I saw your food review of the steakhouse there.
Oh yeah. It's always.
Where was it?
so-
Where was it?
Sorry.
Where
New
was
York.
it?
Oh, yeah, quite a few. There are quite a few. Yes, Peter
Okay.
Luger. I'm sure you know about it. Yeah, and yeah, Keen's very good as well.
I think that is really valid idea. I think Andrew should seriously think about this. It would be a special program for Apple. And we
I think
welcome
we should have one of these what we call this extracurricular stuff in the conferences, right? How
Exactly.
like master class in doing selfies and PC your camera skills as well.
Big selfie. Big camera selfie.
Or PC, you're also an expert in the harmonica, right? So you should have a expert.
Yeah,
I mean,
harmonica
a combined conference.
masterclass.
Harmonica masterclass.
Yeah. Whatever thing you can think about. Yeah, who may like it. Yeah, very much. Good. Yeah. When I was in Bahama last time in 2014 or 15, yeah, I did play some harmonica there because Mark invited me to play some music during his presidential dress. So it's very special. Yeah.
I'm trying to see whether other speakers are coming in because it's going to be, I think it's 10 minutes from 9.
10 minutes.
or
10
Yeah.
minutes.
From 8 o'clock. Yeah.
I texted Jeff to see, just to remind him who's joining.
So as you know, this Greg Bain is not able to join us on Zoom because he's over he's 40,000 feet now. so he has kindly given his pre-recorded lecture, so we'll play it during the I think it's the last session or the last speaker of the webinar.
Is Jeff Ecker joining?
I'm not too sure he's been told about it. Yeah, but he's not involved in the speaking engagement this time around. So yeah, but he should come in as a president, as a new president. Yes, correct. I'll send a reminder to him just so.
Ilya, just now Toshi Nakamura's video is a bit choppy. Is there any way you can optimize it? I don't know if the file is too big or something. Do you know? I mean, the sound was just a bit choppy.
That's what I've been looking at too. I tried a few different things to see if it sounds any better. I can try it again if you'd like.
Sure, let's check it.
Or if Toshi can join in person, he can actually present in live. Then maybe better even. So Andrew, do you know Toshi will join in?
Toshi,
Signal.
yeah, Toshi is not on. Toshi's here already. Can I see? Is that him? Or that's
No, that's the video. That's the video.
Oh, that's a pre-recorded thing. Okay, let me see.
Can you run it again, Ilya, please,
Mhm.
to see if it
I'd like to talk about the diagnosis.
the sound is still kind of choppy and soft.
Are you able to optimize the sound?
I was trying to change its output and things too, and I didn't sound any. Does it still sound the same way? Still sound the same way?
Yeah, still kind of choppy. Can you turn up the volume to the maximum? Is it maximum already, the volume?
Not currently, but it was already.
You can see if there's no tear problem cartridge.
This is a little bit better. We hear him a little bit better.
Okay.
Yeah, I think.
Is there anything else you think I should try?
Hi, Toshi. Hi. Hi. Are you able to tune into the webinar? Okay, I'll see you in the webinar then. Thank you. Okay, it's starting in 10 minutes. Okay, see you. Okay, I just got in touch with Toshi. He's coming in.
So is he going to present live then, as opposed to using the video?
I'm not too sure, but he's coming in, so we can hopefully ask him whether he wants to present it through his own computer. Then we can get him to share screen. Yeah.
Okay, sounds good. So we're just missing Jeff, right? Everybody is here except for Jeff Yao.
Yes.
Yeah, I've texted him as well. So
okay.
It must be 6 a.m. in California or 5 a.m.
Yeah, it's like
5
almost almost 5 a.m.
Yeah.
Yeah, it's right on the other side of the the continent.
Yeah.
Tonight we have many Jeff.
Yeah.
Jeff and Jeff Ekai is coming in. Jeff.
Free Jeffrey.
I think what we'll do is about a couple minutes before 8 a.m. Eastern time, or in about 3 minutes from now, we'll just turn all of our screens black, and then Ilya will let all the attendees in at that time, and then I'll introduce our moderators, and this will be exciting. So we'll get going, and we'll go from there. Is Jeff Yao's talk toward the beginning or toward the end?
It's towards the end. It's in the second session.
Okay, so we have a little of time too, so he can jump on in the middle, so not a big deal.
Okay.
I think it should be good. Okay, awesome. Any questions from anybody?
Andrew, you're muted. Oh, I think he's probably talking to Toshi.
Oh, got it. Okay.
Yeah. All right.
Yeah. Okay, cool.
All right. Well, thank you again, everybody, for taking part in this.
Thanks. We'll see you in a few minutes.
Okay. Sorry, guys. I just got in touch with Jeff Ecker. He's not aware of this webinar, so I was wondering whether could just send him the could we send him the link? You're muted, Sonu.
Ilya, are you on? Are you able to send Jeff Ecker the link?
Okay, can I give you his telephone number so they can WhatsApp him?
The number, what was it again?
+61. Got it? +61 403 460 099.
Okay.
Yep.
And does he have a preferred email address?
You hold on, but I think mobile will be the faster way because I just contacted him to WhatsApp call.
I just sent him the email with the Zoom link. So Andrew, you can alert him to open the email, then there will be a Zoom link.
Okay. I will call him again.
Is this for Jeff Yao or
Jeff Ecker. Jeff Ecker, our current president. Our current president.
Got it. But Jeff Yao did text, so I'm gonna have him that he's joining the webinar, so maybe he might be joining right.
Hey Andrew.
Yeah, so PC just send you the link. Do you receive it in your email?
I'll look at it now. Jesus, guys. Okay, I'll just give you 3 seconds. I'll see if I can open this up. Who organized this?
This was organized before you were president. This was organized during when yeah.
This is beyond me. So,
don't worry about it. Yeah. You got it.
Bloody hell. This is not a joke. No, I've got joint contractors. I haven't just sent me a link. Give me 3 seconds.
Yeah, are you able to get in?
I'll give you 3 seconds.
Mm-hmm.
So I think we're at 7:59, so we should probably all like turn off our videos and all that and let Ilya get started.
Yeah, sounds great. Thanks. Good morning, afternoon, or evening, wherever you may be. I'm Sonu Jain at the University of Cincinnati, and I'm pleased to welcome you this weekend to the Global Hand-in-Hand webinar series of the American Association for Hand Surgery. This is in collaboration with the Asia Pacific Wrist Association. We'll be discussing what's new in wrist arthroscopy in international perspective. Please let me introduce our moderators, Dr. Harvey Chim at the University of Florida and Dr. Andrew Chin at Sing Health.
Thank you very much, Sonu. I'm so excited to be co-moderating this webinar with Andrew Chin from Singapore General Hospital in Singapore. So this promises to be a really exciting collaborative webinar. It's first of its kind between the AAHS and APWA. So the objectives of this session are to discuss the use of wrist arthroscopy for managing carpal fractures and instability, appreciate the use of wrist arthroscopy for distal radius fractures, discuss wrist arthroscopy for management of DRUJ and TFCC lesions, understand applications and use of thumb CMC arthroscopy, as well as recognize future developments in wrist arthroscopy. And really, it's only an hour and a half, but hopefully we'll be able to cover most aspects of wrist arthroscopy and everybody will take back something useful today. So following this, we're going to have 3 talks by distinguished speakers, followed by a Q&A session, followed by another 3 talks, followed by another Q&A session. So Dr. Toshi Nakamura and Greg Bain are not able to join us in person today, so they have actually provided pre-recorded videos. So please mute your microphones. Please turn your camera off while speakers are presenting. Cameras can be turned on for Q&A. Please ensure your Zoom screen name is your first and last name. And do please ask questions in the chat. We do want this session to be engaging and interactive. Thank you again so much, everybody, for taking time to join us on a Saturday. And I'd like to turn it over to Dr. Andrew Chin, my co-moderator, who is Secretary General of APWA, as well as previous head of the Department of Hand Surgery at Singapore General Hospital in Singapore. Andrew, please.
Hi, good morning, good morning, good afternoon, and good evening for those of you who are in different parts of the world. It's a great honor to be able to share this moderating together with Harvey, my fellow co-moderator from AAHS. And we certainly want to warmly welcome you to this webinar. And most importantly, for the next 1.5 hours, you'll be having this very exciting program with eminent speakers from both associations on the subject of what's new in wrist arthroscopy and international perspective. So each of our speakers will have 12 minutes to talk. And then after which we will, for the first 3 speakers, we will have a Q&A session. So please keep your questions coming, everyone. And certainly we want to be able to have these very interactive sessions together with the speakers. And without any further ado, I would like to launch the webinar now with the first speaker. May I invite PC Ho, Dr. PC Ho, who is affectionately known as PC by many of us. He's no stranger to the wrist arthroscopy world. This talented surgeon has described so many wrist arthroscopic surgical techniques and has generously shared them in countless journal publications and book chapters. And he has tirelessly traveled all over the world to educate and teach many of the surgeons on final techniques of wrist arthroscopy. And I myself have been one of the fortunate ones to benefit from his direct teaching and guidance. He's also our founder and the inaugural president of APWA, which is now in its 9th year of existence and going from strength to strength. So it's my honor and privilege to be able to introduce him today to talk on one of his pet topics, arthroscopic bone grafting for scaphoid non-union and malunion. PC, over to you.
Thank you very much. Can you switch on my screen first? Okay, can you see my screen?
Yes, we see you.
Thank you very much.
I can see you.
Yeah, thank you for the very kind invitation, and thank you, Harvey, Sunil, and also Andrew for the very kind introduction. Yeah, it's a great privilege to start this great webinar today with a joint collaboration of the APWA and also the AAHS. Thank you so much. So yes, as I mentioned, I will talk about my grim topic. It's about the scaphoid non-union and malunion. So this is my first idea about the scaphoid non-union with the arthroscopic bone grafting. It was back to already 27 years. So at that time, I was having a case of an acute fracture. So I fixed it with percutaneous screw. You see, at that time, we were just having this sort of big screw, but it's fixed well, but unfortunately, it didn't heal in 5 months' time. So I took a curiosity to see why it didn't heal. So I took a scope into the mid-carpal joint, actually found that the fracture site was filled by some fibrous tissue, which blocked the healing. The screw is still intact. So I certainly have an idea, maybe I should take some bone graft from the distal radius and then put it into the empty site to see what happened. And in 3 months' time, it quickly healed. So actually, this sparked off the entire idea that now possibly the scaphoid non-union can be treated arthroscopically. So here is a typical case I want to show in the more recent years. So it's a 30-year-old sushi maker, right wrist injury after 7 months. So you see this is a very typical of non-union, very mobile, non-union and very sclerotic end, and also associated with quite significant humpback and also DC deformity. So this is our typical setting. We use no tourniquet. We use wet arthroscopy And this 3-liter saline bag by gravity is the way to prevent some bleeding from inside the joint. So classically in the bone grafting situation, we can use a mid-carbo ulnar as a beginning portal because it's usually easier to get in. A mid-carbo radial will be the working portal, or in some of the more distal non-union, we will also use the STTU portal. So this is a typical finding in the mid-carbo joint. Here you can actually see the scapulae junction, and very quickly you can already it went into the non-union site. This is a very typical non-union, very sclerotic bone end, and also a lot of fibrous tissue. So first thing is doing under debridement with some shaver. You just clean up the non-union site to make sure that you can assess the non-union site more easily. And I often use the radio frequency to help to clean up a bit. Usually we use a burr, the proximal fragment using 2.9 millimeter burr. I always do the burr because the proximal side is more difficult. So until you reach the cancellous bone, then it's the end. Then of course in this case you can actually see some bleeding, and you don't need to debride further. Then you debride the distal fragment. The distal fragment in our experience always has good bleeding, and they're actually very prone to bleeding. So just under a little bit debridement, it already has good bleeding. So you see the debridement of the non-union with this technique is very conservative. We just debride what we need to debride. And in this case, the challenge is also at a compact deformity. So we will go ahead with using the Lynchline maneuver. By flexing the wrist, we can achieve align the radius with the lunate, and we transfix it with 1.6 millimeter KY. The proximal lunate, the lunate will actually connect with the proximal scaphoid. In this sense, we can actually do some manipulation to reduce the distal scaphoid, to realign the scaphoid and also to get the adequate length. We will put that KY. This KY, as a temporary fixation of the two fragments, we will tend to place it in a more eccentric manner. In the sense that it does not impede the bone grafting from the mid-carbo joint. So this is a typical equipment we use. So we use a 5 millimeter choker cannula, which can be inserted into the mid-carbo joint. And most of the time we use cancellous bone graft from the eyelid crest, and we cut it into small chips. We're using flat end choker to push the graft into the non-union site. So bit by bit. So this takes some patience for you to do so. Usually we have to pack the basal layer with the larger piece of bone graft in order to reduce the chance of leaking of the bone graft into the wrist joint, and then gradually we'll fill up the space. With time, we actually impact the graft. So this is very important for the graft impaction. That's actually will require a lot more cancellous bones than just the volume of the defect show up. Usually, typically 3 to 5 times of the volume of the defect. And this is almost the final layer of the bone graft. We used this spatula to model it, to shape the non-union site to make it into like the carbo bone shape. Some excessive graft which has been leaked elsewhere, we can actually push it back into the non-union side with various technique. And after the final packing, we will dry the wrist joint. And then because we are going to inject some fibrin glue. So these fibrin glues help to stabilize the bone graft and also form a barrier between the bone graft and the capitate, which has helped to prevent some abrasion adhesion to the cartilage over there. So after all, we will just proceed for 2 more KY. So the 3 KY technique is a typical use in most of the case, particularly for those cases with carpal collapse. So these wounds are very small, and then we don't put even any stitches. The KY in the scaphoid was cut short so they can be very under the skin. So in the radiolunate pin, we will take it after 2 weeks, and afterward we start the mobilization. And the scaphoid pin, because of the very underneath skin, we don't worry about mobilization, and usually will be removed under local anesthesia at 10 to 12 weeks. So you can see this patient actually healed up very nicely in 1 year's time. You can see that the scaphoid alignment was very good restored, and also patient has a very nice functional range of motion and also function. So since 1997 to this is the data to 2017, we have 128 wrists. The non-union duration median is about 42 months. Some of them are chronic smoker, many of them are sport-related injury. And BC deformity is actually quite common in up to 50% of the cases. Most of the time we're using bone graft from the eyelid crest, and most of the time we're using 3 KY technique in 3/4 of case. We use screw for those less deformity and also more fresh non-union situation. The overall clinical radiological union is 89%. And some case is remaining ununited, but a case will require revision surgery. So here's another case with a chronic DC deformity and humpback deformity. So this is actually after a few years of time, so you can see the proximal pole can be very sclerotic. But with this patient, you just remove down to the cancellous bone. And here is the Lynch-Shine maneuver. We flex the wrist, pin the radiolunate joint. And pinning the radiolunate, you can see by manipulation, you can actually manipulate the distal scaphoid fragment so as to restore the angle, the intrascaphoid angle, as well as the length of the scaphoid that is required. Typically, we insert a KY which is eccentric. Eccentric means in the sense that it's actually closer to the proximal end on the volar side. And this is usually how the way that we prepare iPress, and we'll just put into the non-union side as much as possible. And then just the same procedure like what we've done before. So here you can see that this is even after 13 years, this patient was actually doing very well. And radiologically, you can see the restoration of the very good alignment. So this technique can be very sturdy and also can be very good to restore the problem. Proximal one-third non-union typically a challenge for open surgery, but arthroscopic surgery is actually pretty easy because the arthroscopic portal will just right over the non-union side. And often you don't require a lot of bone graft to put in, and you can get some sort of healing. In this case, even after 27 years out of the non-union, it can still heal up. One challenge is because it's proximal, so sometimes if you put the bone graft through the non-union side, it may actually escape in the radiocarpal joint. So the technique
Is PC still with us?
Yeah,
Looks like
he's not. He's lost his connection, right? Yeah, let me call him.
Sorry, everyone. Is that I lost the connection?
Welcome back, PC.
Okay. I'm sorry that you suddenly lost all the connection. Should I continue?
Yes, please continue.
Yeah, thanks. Sorry. Now I think I'm come up to this point. Okay. Okay, so I just continue. Sorry for the problem. So with time, we also have to encounter cases with the malunion, particularly for those symptomatic malunion with significant deformity. So it is also possible to deal with the malunion with the arthroscopic technique. What you need to do is you use a small osteotome, which can be inserted from the mid-carpal joint to locate. Sorry, anything wrong here? My screen lost. Excuse me.
Yeah, back again. Yeah, back
okay.
again. Yeah.
Sorry. Maybe I start again for this slide. Yeah. So the osteotome can be inserted from the mid-carpal joint and locate the malunion site. And what's the aim is actually try to create a gap. And usually this is already healed malunion. They usually break quite readily. And sometimes you may just need to burn a little bit of proximal fragment in order to increase the blood supply. But very importantly is to preserve the volar capsule, because often you actually impact the bone graft. You need to protect the capsule. Otherwise, you will actually leave to outside the joint. So against the bone graft, we'll be using a lot of cancer bone graft from the eyelid crest, and then you pack into the key point is really pack a lot of bone graft so that you can completely fill up. So you can actually see that after the final packing, the bone is so dense radiologically. And then you just continue with the additional KY and do the similar like the last case. And because it's different from a non-union situation, it may take more time to heal, but in male union, because they are already healed already. So the union is not a problem. So as you see that by 6 weeks of time, the KY can be removed and you can already attain a very solid, stable union. Another male union case, you can see also very big hump and DC deformity. We did it similarly using a lot of bone graft, correct the scaphoid very nicely. And again, for this minimal invasive technique, typically the patient can achieve very nice range of motion, also clinical function. And even in this case, after 12 years, the scaphoid alignment was still well maintained and there's no arthritic changes. Recently, my colleagues, Dr. Michael Mack, also want to improve the accuracy by adopting the computer assist technique using the pre-op planning, as well as intraoperative navigation combined with the arthroscopic bone graft and try to do a more accurate reduction of the malunion. So typically, we're using the other side of the wrist to mirror the scaphoid so that you can actually to work out the exact volume deficit of the scaphoid malunion site and to plan the bone graft site. So during the operations, we were using some titanium pin to pin the radius to the scaphoid cavity so as to immobilize the wrist. And then you're using two pin from the distal pole of the scaphoid, planning to maintain the reduction of the scaphoid and after the correction of malunion. So with the intraoperative CT, the image can be matched to the pre-op planning so that the two pin can be placed exactly in what we want before. And then the next thing is that in the intraoperative navigation guide using the oscillotome to also correct the malunion exactly in the preoperative planning site, and also the amount of the reduction and also the correction of the alignment and also the angle. And then we will just insert the two KYs to maintain the two fragment alignment and subsequently just doing the typical taking down the malunion and also using the bone graft to fill the non-union site and then followed by the additional pinning. So this case actually achieved very nice reductions and also excellent clinical functions. And there's a good improvement compared to pre-op status. And most importantly, the patient can resume basketball playing. So it's very important for the patient. So over here, we try to look at any factor which may affect the union rate. We look at the age, injury site, occupations, duration of non-union, smoking, sport-related, no relationship. We also look at the fracture characteristic like the non-union location, any DC deformity, whether using KY or screw fixation, the surgeon experience and learning curve. Again, there's no correlation. The only factor may affect union, at least in our cohort, is the bleeding. If the proximal fragment bleeding is not good, the healing is about 8.8%, which is probably still not bad. But if this is a good and flat bleeding from the non-union side, there's a very high chance of getting union. Recently, there's a systemic review on this technique, which have been now adopted by many centers. This 545 subject in this 18 study actually has achieved a union rate also very high, 93.7%. And they actually found that there's no difference in union rate when using the cannula screw or the KY. And it seems that the eyelid crest bone graft associate better union rate. It concluded that this arthroscopic bone graft is actually quite a good technique. Also recently, a prospective multi-center study also conducted in France with 10 centers with 77 patients. They did it in an outpatient basis using the ipsilateral radius as a bone graft and using the bone marrow biopsy trocar. And also using the rev screw and KY, achieved a union rate is also similar with the 93.5%. Again, they found that the union is not affected by tobacco, delay from trauma, fracture location, intraoperative bleeding. So actually, pretty similar to us, except the bleeding will be actually, we think that bleeding may still have some bearing. And also some Korean surgeons also try to compare the ABG with open technique. Actually, there's no difference in union rate, except the ABG actually may achieve less correction of carpal collapse, although there's no clinical significance. Our president, Jeff Ecker, also compared with the vascular bone graft with the medial femoral condyle bone graft, and also both heal similarly, but there's less pain in the ABG and also slightly increase in range of motion in the arthroscopic technique. So to conclude, I think after 7 years, I got a feeling that perhaps APG is perhaps the universal solution for all scaphoid non-union. And I think now there's some evidence. So thank you very much. I think this is a great privilege for the APWA to be able to join this collaborative work with the AAHS. Thanks so much.
Thank you so much, PC. That was really outstanding and really amazing results. Congratulations on that. Next, I'd like to introduce the next speaker, Sanj Kaka. Dr. Sanj Kaka is a professor of orthopedics at the Mayo Clinic and medical director of the digital platform within the continuous professional development at the Mayo Clinic. He has authored more than 220 peer-reviewed papers, 45 book chapters, and is co-editor of 4 orthopedic textbooks in the hand and wrist. And he currently also serves as editor of Hand E for the American Society for Surgery of the Hand. Sanj is, for me, both a good friend as well as a mentor, as well as an expert in wrist arthroscopy. So I'm really looking forward to your talk, Sanj. Please go ahead.
Thank you, Harvey, Andrew, and Sonu. It's an honor to be here and following PC, and I can just only echo the comments that were made earlier about PC and how he's really taught the world and how to do arthroscopic bone grafting of scaphoid non-unions and many other procedures about the wrist. I have the privilege to talk about arthroscopic treatment of scapholunate ligament injuries and primarily concentrating on capsulodesis, but we'll touch on tendon reconstructions. These are my disclosures. Some of the surgical videos are on handy, as Harvey mentioned, and if you have your phones out, this is a QR code that will take you directly to the website. So in terms of the surgical treatment, there's numerous factors that we have to consider in treatment of scapholunate ligament instability in a short period of time. It's hard to go over all the kinematics and etc. So we're going to concentrate on the surgical pearls. And in terms of an acronym, I use this one when trying to sort of think about the myriad of different treatment options and what factors you need to think about. So you need to think about secondary stabilizers or the critical stabilizers, and we'll talk a little bit about that, namely the DIC, the DRC, the long radiolunate ligament, and the STT ligament. You have to look at the cartilage. Is it arthritic or not? Because if it's arthritic, it's hard to do a repair or reconstruction. It may be too late. I think lunate alignment and scaphoid dorsal translation is also important, because if they are injured and the carpus is malaligned, we need to think about reducing that. Then comes on to reducibility. Sometimes you can use fluoroscopy to guide reduction of the carpus. Typically, I use arthroscopy and use the shaver to try and take down scar tissues, because if the carpus is not reducible, soft tissue repairs or reconstructions most likely will fail. Chronicity, is it acute or chronic? Acute tends to heal easier than chronic, but you can get a good repair with chronic injuries. And finally, the location or the extent of the injury. Is it dorsal, is it volar, or is it through and through? This is a busy slide, deliberately so, to show you how complicated this is. But essentially, if you have DZ or extension of the lunate, it's not just a scapholunate ligament problem. You have to think about these critical stabilizers. There was a recent two-series article in Journal of Hand Surgery by Scott Wolf, and I urge you to read this. It really is a wonderful overview of this problem. And if you look at this classification system that's proposed, you can see, starting from occult to all the way to frank instability, you can see the gradation or the increase in injury of the various types of ligaments. These next slides are a powerful series of slides that show the importance of some of these critical secondary stabilizers. So essentially everything has been taken off here, apart from the scapholunate ligament complex and the DIC and the DRC ligament. And so here what we've done is, what's been done here is the volar and membranous portion of the scapholunate ligament has been cut. The DIC and the DRC ligaments are intact. And when you load the wrist, you can see there's a little bit of instability of the carpus, but it's really not too bad. Now, when the SL is completely cut, now you'll see just with the DIC and the DRC ligament, so a complete scapholunate ligament injury, again, when you load the wrist, there is some instability of the carpus, but really, again, it's not too bad. It's only until the DIC is completely torn that you see gross instability. And so I put these slides here to show you the power of these ligaments, because these form some of the basis of some of the surgical treatments. We were taught many years ago about the different types of open capsulodesis, the Blatt, the Szabo, or the Berger capsulodesis, and the outcomes have been reported. But I think it was really the seminal work by Christoph Mathlewin showing the power of arthroscopy and how one can essentially reconstruct this so-called dorsal capsular ligamentous septum of the scapholunate ligament. And essentially in his technique, in this schematic, what you're trying to do is create a tether between the dorsal capsule and the dorsal aspect of the scaphoid and the lunate, the so-called DCSS repair. This was a study done many years ago. He's since done hundreds, if not thousands, of patients with excellent outcomes. In this series of 57 patients, you can see a varying degree of instability. Some of those were, for example, in stage 4, KYs were used, but in the vast majority, KYs weren't used. And the outcomes truly are remarkable, a 98% satisfaction rate. So this got me sort of interested in this type of technique. This is a very short video showing how to do this. And essentially you have the camera in the 6R portal, and then this is looking across at the carpus, and invariably there's a lot of scar tissue between the dorsum of the capsule and the carpus. So you're taking the shaver here. You can see that the shaver is kept away from the scapholunate complex. And once you've got this area cleaned, you then take a needle, you take a wide bite of the capsule adjacent to the scaphoid. You can see you can drop your hand and you take a wide bite just dorsal of the capsule or the scapholunate complex on the scaphoid. You do the scaphoid side first, and then again you come in, take a wide bite of the capsule with a K-wire, and then drop your hand. And you have to see the degree that you have to drop your hand and you're taking a bite. You can see I just pushed in there on the lunate. You then go into the mid-carpal joint. You put the camera in the mid-carpal ulnar portal, and the grasper comes in to the radial mid-carpal portal. And in this technique, what we've done is typically Christoph had described putting 2 sutures and tying a knot. I used to always be concerned there that the knot could break. So what we've done here is just shuttle a wire loop, and you've got the suture, you grab them together so you don't get a soft tissue bridge. And then you simply shuttle this suture through that loop. And you can see now when you pull on this, it gives you a reduction of the scapholunate complex dorsally. So knowing this, can we do this on the volar side? Because many times the patients, as you remember, the volar side is weaker than the dorsal side. It'll tear from volar to dorsal. So here's a patient who comes in, manual worker, with a truly non-displaced scaphoid fracture. You can see the CT scan, and if this was my wrist, I would treat this non-operatively. And sure enough, we treated him non-operatively. He comes back 3 weeks later for a cast change. And this is his x-ray. And he's like, you know, doctor, I've heard about scaphoid non-unions. I'm concerned about this. I want to get this fixed. So typically what I do is we know that fluoroscopy can underestimate the degree of malrotation of the scaphoid. And so I typically put the K-wires in and then I judge my reduction. And so here you can see that the scaphoid actually looked well reduced. And so I was happy with this reduction. I then checked the scapholunate area, and you can see there's gross instability volarly, but dorsally actually looked pretty good. And so I put the scaphoid screw in. And so what do we do for the scapholunate interval? I could put a scaphocapitate wire, but it's really harder to do with a scaphoid screw. And so this is taking the principles of what we've learned from the dorsal side to the volar side, doing an arthroscopic capsulodesis. And so you can see here as I place this suture, how by pulling on that suture, it reduces the scaphoid and the lunate interval. And so this is a short video of how to do this. On the palmar side, you need to make either a volar radial or a volar central portal. Having done that, you can see that the camera is in the ulnar mid-carpal portal. There's a needle loaded with a suture. You can see we can look at the scapholunate instability. You always need to probe this to look at the cartilage, to look at the reducibility, and also to see where the tear is. Is it dorsal or is it volar or through and through? I think the shaver always helps to debride a scar to make this reducible. And after doing this, you take the needle, you go through the radial mid-carpal portal, take a wide bite of the capsule adjacent to the scaphoid. You can see it's being pulled out of the volar portals. You then pull the needle back, but stay within the mid-carpal joint so you don't get a soft tissue bridge, and take a wide bite of the tissue adjacent to the lunate and simply pull these through. So by not coming out of the mid-carpal joint, you won't get a soft tissue bridge. And so by pulling on the suture, you'll now be able to see how that suture now can address the volar side and really is a powerful adjunct to doing dorsal procedures as well. We reported a small case series earlier on, and what we noticed was not only was there improvement of the gap, but also improvement of the radiolunate and the scapholunate angles. Paco del Penal has also described a similar procedure, doing outside to in. So I think it's really dealer's choice, either inside out or outside in. So here's a patient that comes, as PC showed earlier, with scaphoid non-unions. You can see had a chronic history of injury and also had pain with wrist extension. And so here you can see dorsal impaction. And that really is the beauty of arthroscopy, because you can address multiple pathologies at the same time. Here's the axial view of the MRI. I urge you to look at the axial views because it gives you an indication of injury to the dorsal and the volar side. So this was a through and through injury. So from the mid-carpal joint, you can see the cartilage looks good. I can reduce it. You can see there's a big, Geisler 4 drive-through sign. You can see dorsally and volarly through this. So gross instability. And so here I've passed the suture from the radial side on the scaphoid volarly. I'm going to come, drop my hand, and pass it through the capsule adjacent to the lunate. And so now you can see, just by pulling on that volar suture, how we're able to reduce this. As I pull on this, you can see the instability on the right. As I pull, you can see there's actually blood coming out between the scaphoid and the lunate. It gives you a nice repair. But this patient also had a dorsal injury, so we can't forget that. And so now you can see I pass the sutures on the dorsal side. And again, just by pulling on this, it gets a nice reduction both now dorsally and volarly. This patient had wrist impaction as well dorsally. And again, with arthroscopy, you can really hone in on your treatment minimally invasively so you don't get too much scarring after this. Our colleagues in Australia, Mark Ross and Greg Cousins, and also Scott Wolf, have shown the importance of that DIC ligament that I showed earlier, how you can repair both the DIC and the DRC ligament with this radical operation where you put a suture anchor in the lunate and tie that dorsal capsule. And that really is a powerful adjunct to treatment of these problems. What about tendon reconstruction? So that was capsulodesis. Well, our first speaker, PC Ho, has taught the world really how you can do arthroscopy for scapholunate ligament reconstruction. And he described this arthroscopic box or scapholunate 360-degree reconstruction. You can see there's 17 patients. A lot of them had a high degree of instability. Note the time of surgery from injury was just under a year. And the outcomes truly were very impressive as well. You can see that the scapholunate interval was about 2.9 millimeters, so a very powerful technique. Fernando Correa has taken this also to the next level, doing an arthroscopic scapholunate 360-degree reconstruction again with excellent outcomes. And then finally, if you like to do the Russell procedure, Michael Hausman in New York has been a big advocate of doing this arthroscopically. The take-home point from this series is when you do place a scaphoid screw, how it should be proximal to the oblique ridge of the scaphoid. So I think in summary, understanding the spectrum of injury, I think, is important. And now I think with arthroscopy, we're beginning to really hone in on our treatments of addressing not only the scapholunate ligament complex, but also these critical stabilizers. I think a plug to all of our colleagues around the world. There's a combined meeting with the American Society for Surgery of the Hand and our Australian colleagues in Maui this May. So we urge you to come, hoping for a great event. Thank you very much.
Well, thank you very much, Sanji, for a wonderful talk on scapholunate instability and capsulodesis that you have so elegantly shown us. We would like to move on to the next speaker. I think we are actually running short, a bit short on time. So the next speaker will be Jeffrey Koo, who will be talking on arthroscopy assisted fixation of the distal radius. Jeffrey is the current board member of the Asia Pacific Wrist Association and the treasurer. He's also a consultant hand surgeon based in Hong Kong. He's passionate about wrist arthroscopy and is taught in many courses in the Asia Pacific region. And he's a subject matter on these arthroscopy assisted fixation of distal radius. So I would like to just invite him as a subject matter expert to talk on his pet topic. Jeffrey.
So thank you, Andrew, for your kind introductions. Maybe I share my screen first. Okay. So can everyone see my screen?
Yes,
okay?
we see you. We see you.
Thank you. Thank you. Can't you happy? So it is my privilege to talk about my experience in using the arthroscopy in treatment of distal radius fractures. So I have no conflict of So I have no conflict of interest to disclose. So from our experience, we know that the distal radius fracture does not often recover as benign as Abraham Collins has said. And Collins in the 80s has told us that there are more than 1/3 of the patients has complications. Most of the time is due to incomplete restorations of the radial length and secondary loss of reductions of the fracture fragment. And there is also associated soft tissue injury and often reported as high as 31% in overall cases. And unfortunately, the diagnosis is often delayed. This becomes the source of persistent pain and disability even after the fracture was healed. Jupiter has a classical paper told us that the articular surface can only tolerate less than 2 millimeters step off. Otherwise, there will be increased risk of post-traumatic arthritis. And in subsequent years, much interest has been put into the effect of the radiological parameters on the functional outcomes. Now, we all know that the radiological shortening and intraarticular gap will affect the functional outcome. Radial shortening is easy to understand as it creates ulnar positive areas causing ulnar impactions, but why articular gapping can cause problems as well. The answer lies in the Gabby's paper that when he performed with arthroscopy in 20 patients at the time of implant removal, what he found is there is fibrous tissue formation from previous fracture gapping and stepping to the surrounding structures, hindering the range of motions and affect our functional outcome. To avoid this, we need better tools for assessment, and CT scan becomes the standard for distal radius fracture to evaluate the fracture convolutions and articular surface status, which is very good for preoperative planning. But there are still unresolved problems such as how to assess the articular surface reductions intraoperatively and how to detect the intraarticular soft tissue injuries. We often judge the adequacy of articular fragment reduction by fluoroscopy. I give you this example. This is a 23-year-old gentleman who had a severe distal radius fracture at the time of a motorcycle accident. During the operations, seems that the articular surface is reduced quite well, but under arthroscopy, you can see that the articular surface is shattered into small pieces. This is because the fluoroscopy always projects the three-dimensional object into a plane image. The articular surface is often overlapped and blocked each other so that we can use the fluoroscopy to reliably assess the articular surface. And latest evidence shows fluoroscopy missed more than half the articular gap and 1/5 of the articular stepping when compared with arthroscopy. And also, X-ray is often a poor choice to detect soft tissue injuries. And arthroscopy is still the standard for detecting the intraarticular soft tissue injuries. So arthroscopy is perfectly indicated in this intraarticular distal radius fracture and case suspected to have intraarticular soft tissue injuries such as TCC, SL, and LTT. To prepare for the operations, we currently need a CT scan of the injured site for the surgical planning and contralateral side X-ray to show us what is the normal risk patients should have. The timing is usually around 1 week to avoid compartment syndromes. You can start it earlier if you use dry arthroscopic technique, but don't wait too long as the blood clot inside the joint and fracture gap will become fibrotic and block the fracture reductions. And the implant of choice is I will use a variable angle roller distal radius locking plate. You use the standard setup for arthroscopy, apply 12 pounds traction using traction tower. For a wheeling portal, I prefer to use the 6-hour portal because it's allowed us to put the scope onto the outer head, which gives us a steady yield and would not depress the dorsal fragment as in 3-4 portals. Then you can use a 3-4 portal as the working portal. At the first time few cases, there are two things that you can encounter when you start using the arthroscopy. First, when you try to reduce the articular surface under the arthroscopy, you may have a difficult time to determine which fragment is in correct positions. Is this one or that one? And there is a method that can help you. Firstly, the roller metaphyseal and acrylic fragment is reduced. Then the roller distal radius locking plate is temporarily fixed on the radius and act as the buttress for the reduced roller fragments. Then the KY is used to temporarily anchor the reduced fragment onto the plate. Since the roller fragment is already reduced and in normal positions, we can use it as a reference point to reduce the remaining dorsal fragment. This can help you to easily restore the overall alignment. Another thing that can annoying you is the wheel obstruction by the blood clot inside the joint. You can use a 10 ml syringe filled with saline, insert in the side valve of the scope, and perform suction by the arthroscopic shaver. This will aspirate the blood clot out of the joint. Then we can use the probe and shaver to dislodge the blood clot inside the fracture gap, and you can start the fracture reductions under arthroscopic guidance. Different fracture pattern and configurations need to use different reduction techniques. For example, if the fracture is depressed, use the probe to hook the fragment or use the additional KY from the dorsal side as a joystick for fragment manipulations. Then you can use your thumb to compress the reduced fragment and drive in the supporting KY. If the fragment is elevated, often it's due to the overtractions. Release the traction a little bit and then use the fear elevator to press on the fragment for reductions. The free osteochondral fragment need to be created cortical opening through the window in the roller plate. Then use the bended 2 mm KYs pass through the cortical opening to push back the fragment back to the original positions inside the intramedullary canal. After the fracture fixations, you can start to perform the arthroscopic surveillance. TFCC, SL, and LT interosseous ligament injury can be directly visualized and assess its severity. For concomitant SL injury, based on the clinical studies, keeping the SL injury in a non-operated manner will lead to poor outcomes with decreased range of motions of the wrist and grip strength. So surgical treatment is necessary for these combined injuries. And grade grade 3 and grade 4 tears should be treated promptly as shown in these studies. They tend to have a more pain and greater degree of SL dissociation 1 year after the injury. Treatment options can be opened SL repair reductions of a SL interval, either for scopic or arthroscopic means, followed by KY pinning or newer techniques that Sanji has mentioned that Professor Mathelin has proposed arthroscopic dorsal capsuloligamentus scapholunate septum repaired. Clinical results in patients having both distal fracture and SL tear and treated at the same time has good to excellent result and no radiographic evidence of carpal instability after the 3 years. Another common associated injury is TFCC tear. At least 1/3 to 80% of the distal fractures has this injury, and 90% of complete peripheral tears has DRUJ instability symptoms. The problem is, it is often difficult to detect the TFCC tear clinically at the time of acute distal fracture because of the pain and the swelling, and presence of ulnar style fractures does not correlate well with the presence of the TFCC tear. Wrist arthroscopy can help us directly visualize, perform tests to assess the type and severity of the TFCC lesions, and then you can provide treatment according to the type of the tear at the very same operations, like debridement in the central perforations, peripheral tear repaired, or foveal tear, depends on the type. Generally, outcome after the operative repair in TFCC tear accompanied by the distal radius fracture is good to excellent. Although the final result may not compatible with the healthy wrist, but at least with prompt detections and proper treatment of these concomitant injuries, functional outcome is the same with those who only have a distal radius fracture. We have a retrospective review on our AO type C distal radius fracture patients treated either by arthroscopic assisted reduction or conventional fluoroscopy, and we have compared their clinical and radiological results. We found that arthroscopic group significantly performs better in articular stepping and gapping reductions, restorations of the radiological parameters, range of motion, grip strength, and modified male risk scores. After reviewing our cases, we are confident that the arthroscopic assisted reduction technique can help our patients with severely comminuted distal radius fractures. So we're coming back to this case with shattered articular surface. Even though we try to reduce the articular fragment as much as possible, but you can see that there's still a large defect inside. So what should we do? Maybe someone would consider distraction plate or partial distribution of therapy, but in such a young age patients, he had a lot of to sacrifice. So we come across this paper by Professor Bummersberger. He has described an open technique using silicon sheets to interpose between damaged articular surface and the carpal bone, helping the cartilage to heal. We did it by means of arthroscopy. You need to prepare this silicon sheet, which is 1 millimeter thick. You fold it and tie it on the knot pusher, use it in shoulder arthroscopy, and insert the silicon sheet into the joint through the 6-hour portal. Inside the joint, you cut the knot and unfold the silicon sheet to cover the damaged cartilage area. Then after the operation, you start the rehabilitation straight away and remove the implant 1 year later. He has a reasonable range of motions and strength, which enabled him to return to his work. AAHS has recently published a guideline, and they show that there's only moderate evidence not supporting the use of arthroscopy in distally fractured. But be careful that the conclusion is made only based on 3 studies. The first one, the first paper has the best articular restoration in articular capping and stepping. I think it's in the world under arthroscopy, which is quite contradictory to our normal understanding. And the second paper does not use the arthroscopy to assist the reductions. They just wash out the blood clot inside. This is only a sham procedure. That paper actually has shown better restoration of range of motions and functional scores in the arthroscopy group, but not mentioned in the guideline. So a good quality recommendation is not yet available at this moment. So in conclusion, width arthroscopy can be important adjunct in distal risk management as it provides excellent visualization of articular surface for anatomical restorations and allow evaluations and treatment of the intraarticular soft tissue injury simultaneously. Thank you very much.
Thank you very much. In the interest of time, because we're running a bit over, I think we're going to move on to our next talk. So thank you so much again, Jeffrey, for your excellent talk. And Andrew is going to introduce our next speaker, Dr. Nakamura.
Yes, thank you very much, Harvey. Yes, for the next speaker, I would like to introduce Professor Toshi Nakamura as to talk on his pet topic on the DIUJ arthroscopy diagnosis and decision making for TFCC lesion. Briefly on Toshi, he's affectionately known in this wrist arthroscopy world for the TFCC guru, and he's one of the foremost surgeons who have done extensive research on this topic and thus the world authority on conditions pertaining to TFCC. He has invented a Nakamura wrist drill guide and described the transosseous technique for TFCC repair, which I myself have personally subscribed to. He was the third president of APWA and the current editor-in-chief of Journal of Wrist Surgery. And because recently has come up with his classification of TFCC lesions from both DIUJ and radiocarpal arthroscopy assessment, he's here to share with us regarding this. So Toshi, to you. Thank you very much. Are we able to play Toshi's recording? The audio seems to be. Can
we go up on the volume again?
Yeah.
I think this is as loud as it gets currently.
Okay. Let's try playing the video again.
The arthroscopy diagnosis is to make AAHS not.
We can't hear, right? Can you hear, Harvey?
No, I cannot hear. Let me try playing it. I don't know if it would help. Okay. we can see if it yeah, let me try and run mine from my computer. How's the volume? Can you hear?
I don't hear anything currently.
Yeah, it's quite muted, despite the fact I can hear him moving his mouth.
Good afternoon. Good morning.
How about this? Can you hear?
That sounds
Yes,
better.
very clear.
Yes.
I'm going to talk about the DIJ arthroscopy diagnosis and decision making for TFCC regions. Arthroscopy Nakamura speaking. There's no COI in this presentation. Triangular fibro cartilage is a ligament fibro cartilage in the ulnar side of the wrist. It separates the radiocarpal and DIUJ scope. So radiocarpal arthroscopic view cannot see a foveal region when the TFC triangular fibro cartilage is intact. So please remember that TFCC separates the radiocarpal and DIUJ joint. So if you would like to see a foveal region or radial ligament, radiocarpal scope is not suitable for the viewing of the DIUJ. Again, this is a three-dimensional structure of the TFCC. You can see hammock-like structure of the triangular fibro cartilage. This is a surface on the radiocarpal joint. Then radiocarpal arthroscope can see a distal surface of the triangular fibro cartilage, but you can see if there's no tear on the triangular fibro cartilage, you cannot see DIUJ or fovea. Then we need DIUJ scope. DIUJ scope offers a direct vision, a direct visualization of the foveal region, DIUJ, and radial ligament. You can see clear view of the radial ligament, but this patient has a complete aversion of the radial ligament, so there is a wide view from the DIUJ. We need 1.9 scope to viewing the DIUJ. Normal wrist arthroscopic standard portion, then portal should be just proximal to the 6R portal. You can see this is a 6R portal, then the DIUJ portal is just proximal to the 6R portal. Normally, I use saline to expand the joint capsule, then penetrating the joint capsule with a bended mosquito. Jeffrey describes a dry arthroscope, but normally I use saline to expand the joint. This is how to make a DIUJ portal. So this is a 6R portal, then this is a DIUJ portal. Then saline was expand the joint capsule, then I put a small incision just 5 millimeters from the 6R portal. So those portals position is depending on how much ulnar variance wrist. So ulnar variance minus variance wrist has a little bit wide distance from the 6R portal. Then positive ulnar variance wrist is very close to the 6R. Then I go into the DIUJ. It's just taken 30 seconds to 1 minute to make a DIUJ once you are familiar with this technique. This is an intact DIUJ viewing. You can see very narrow area of the ulnar head and proximal surface of the triangular fibro cartilage. You can see palmar portion and dorsal portion of the radial ligament. Then you can also see an ulnar head and sigmoid notch joint surface. But normally, the TFCC aversion patient is much more easy to for DIUJ scope viewing. This is another intact radial ligament. You can see an oral portion and dorsal portion of the radial ligament attaching at the fovea. This is a normal diagnoscopic view in the DIUJ instability patient with an avulsion of the large ulnar ligament. You can see ulnar head here, sigmoid notch here. And as this patient has a severe DIUJ instability, then you can see a proximal side of the triangle fiber cartilage. Then here is avulsion of the large ulnar ligament. You can see a remnant of the large ulnar ligament. Then I put a 23 gauge needle to check the condition of the large ulnar ligament. As this patient has a complete avulsion of the large ulnar ligament, so there is no tension on the foveal region. This is another patient who has a positive ulnar variance, positive 3 mm variance wrist. You can see ulnar head here, then proximal TFC and foveal avulsion. So even positive ulnar variance wrist, you can insert the DLG scope if the TFCC was completely torn. Here is ulnar head sigmoid notch, then proximal surface of the triangle fiber cartilage. This is a little bit steep angle. Then here is the foveal. You can see completely avulsion of the large ulnar ligament. This is a remnant. So when I palpate from the distal dorsal or palmar side, then here is a flappy large ulnar ligament because this patient has a completely avulsion of the large ulnar ligament. When I actually did DLG scope in 196 wrist, then successful rate was almost 85%. Then 26 wrist, I cannot see a foveal region at all. Then other 170 wrist can be separated or classified with a complete avulsion or partial avulsion. Then the dorsal was much more dominant to the palmar. Then 20% showing the relaxed large ulnar ligament. Then 10% has an intact large ulnar ligament. Here is the variety of the large ulnar ligament findings. You can see complete avulsion or empty large ulnar ligament surrounded by a synovial tissue or partial tear, or relaxed large ulnar ligament, which is a good candidate for ulnar shortening. Then intact large ulnar ligament showing a very narrow view of the DIUJ. Then I also separate the staging of the large ulnar ligament tear from the stage 0 to stage 4. Stage 1 is a slit tear, stage 2 is a partial tear. Either 2A is the dorsal, 2B is the palmar. Stage 3 is the complete tear of the large ulnar ligament. Then the stage 4 is the relaxed large ulnar ligament, all degenerative findings, which was submitted and published in a German hand surgery journal. Then I found that almost half of those are intact. Then 24% has a slit tear. Then complete tear is 12%. On 5 wrist, I cannot see a DIUJ because of the excessive scar formation. I also selected the treatment according with the staging. Stage 1 is just synovectomy. Stage 2 is partial avulsion. Then normally I do an arthroscopy repair. Then stage 3, I do an arthroscopic open repair, or sometimes, very few cases, I need a reconstruction using an ECU reconstruction. Then stage 4 is normally for the ulnar shortening. This is arthroscopic transosseous TFCC repair. You can see, and I do a bone tunnel making with a drill guide. Then I made an transosseous repair with a drill guide. This is a view that KOAs come from the outside of the ulnar cortex inside the triangle fiber cartilage. I put a parallel bone tunnel with 2. Then once that's inside the tunnel, I put a 21 gauge needle Then inside there is loops. Then loops can introduce the main stitches. This is the Tycon stitches which can be anchoring the triangle fiber cartilage onto the foveal region. Then I obtained excellent clinical results. Another option is open repair. That when I see a lot of scarring as a fovea, then I selected an open repair. Still works very well. Then if the ligament cannot be repaired within the stitches, I do a reconstruction using a half-strip PCU tendon with an interference screw, which can indicate the normal anatomical structure of the triangle fiber cartilage. Then I do also that put a bone peg into the foveal region, then using the interference screw to fix the tendon to the fovea, like an ACL reconstruction. This is a treatment algorithm that I do on a scope first, then there's a variety of radial ligament findings. Then all of those can be separated in the adequate treatment technique from the arthroscopic repair, open repair, reconstruction using the ECL half-strip tendon, or ulnar shortening. A version of the radial ligament as the fovea reads DLJ instability. Then we need DLJ scope to see this area. Then it offers direct vision to the fovea, direct vision of the ulnar head and sigmoid notch, and also that I can check the integrity of the radial ligament. However, it requires the 1.9 scope. Then everybody says that this is a technically difficult technique. But again, that this has a great advantage for direct visualization of the foveal region or radial ligament. Then it helps on the decision making for TFCC repair or reconstruction. Thank you for your attention.
Thank you very much. Our next speaker is Dr. Jeff Yao. Jeff is a professor of orthopedic surgery at Stanford University Medical Center. He has won multiple awards for research and also is a past Bunnell Fellow by the ASSH. He's currently the Hand and Upper Limb Extremity Fellowship Director at Stanford University Medical Center, and he is an expert in arthroscopy and minimally invasive surgical techniques for the management of common upper limb disorders. Jeff is also a great friend and mentor, and I'm really looking forward to his talk on thumb CMC arthroscopy. So Jeff, please.
Thank you, Harvey. Can you hear me okay?
Yes, we hear you great.
Great. So I apologize in advance. I'm just getting over a little bit of a cold. Hopefully my voice will hold up. But thank you very much, Harvey, Sonu, and Andrew for inviting me to participate in this great collaboration from around. We have attendees from around the world, so this is fantastic. I'll be talking about thumb CMC arthroscopy today. Just quickly, I'd like to put a plug in for the triennial IFSSH meeting, which we will be hosting in the United States in Washington, D.C., March of 2025. I encourage everyone who's on this webinar to attend. This is where I'm from, Stanford University. It's early in the morning here, and this is my email address in case anyone has any questions. As I said earlier, I think this is a fantastic collaboration between AAHS and APWA. Being on the West Coast of the United States, I can legitimately say that I have a legitimate claim to be a member of both groups, and I think they're both fantastic groups. Okay, here's my disclosure slide. And again, I'll be talking about thumb CMC arthroscopy with my talk. Some of the best indications in my mind of using the scope in the thumb, number one is treatment of a Bennett's fracture. We know that closed reduction and pinning can be performed very easily, but sometimes fluoroscopic alone, guidance alone, may not definitively identify your reduction well. And in those situations, I do like to use an arthroscope. Here's one of my cases. You can see the Bennett's fracture in the radiograph on the left. This is my typical setup with traction on the thumb predominantly. You can see I've drawn out the metacarpal. The main portals we use are the 1U, the 1R, and the thenar portal. The 1U is ulnar to the extensor pollicis brevis tendon. The 1R is radial to the abductor pollicis longus tendon. And the thenar portal is about 1 centimeter volar to the 1R portal. So that gives you an orthogonal access point to the thumb CMC joint, orthogonal to your other portals. I would encourage everyone on this call who's doing arthroscopy to try thumb CMC arthroscopy if you haven't already. A lot of people are intimidated. They think it's a small joint. They think it's very difficult to get into. But quite honestly, it's a very easy joint to get into. In fact, I think it's easier to get into sometimes than the midcarpal joint of the wrist. Here's the setup again, which I just described. 1U, 1R. There are some other portals that have been described, but for me, the workhorse are the 1U and the thenar portals. Now, often when treating Bennett's fractures, when you first get in there, it can be very daunting. It's red. There's hemarthrosis, fracture hematoma, and the visualization can sometimes be very challenging. But I would submit to you, just be patient with it. Get your shaver in there, clean up all the synovitis, clean up all the debris, and you can get a very nice view very quickly. And again, this is a 3.5 millimeter shaver, so the space is quite large. You can see you have lots of room to maneuver in this joint. Then once you clean out all the debris, you can see the fracture, and you can use a probe to clean out the fracture sites, clean out any callus that's there, and then reduce the fracture. And there's nothing better than arthroscopic reduction or arthroscopic assisted reduction. You can visualize the reduction much better than you can with a fluoroscopy unit. Now, once you're holding your reduction, you have your assistant place some K-wires through the metacarpal and either into the fragment itself, into the second metacarpal, or into the trapezium. It doesn't really much matter. I don't think you need to completely secure the fragment itself, as long as you reduce the metacarpal and keep it out to length. And that's quite simple. I leave those pins in for 4 weeks, and then we start therapy. So very good use for arthroscopy in the thumb. My mainstay use of arthroscopy in the thumb is for CMC arthritis. Here's a typical patient with Eaton stage 2, maybe 3 arthritis. This is a very nice case for arthroscopic management. As you know, there are many open methods of treatment for thumb CMC arthritis. I'm not here to discuss all of them. Suffice it to say that all of them are effective. All of them provide reliable relief of pain as long as the bone-on-bone pain generator has been removed. But meta-analysis do favor just removing the bone and not doing any other ligament reconstruction or interposition. But we know that with open treatments, there is the potential for prolonged recovery. And so arthroscopic management was described in the 1990s, actually, by Dick Berger and Menon. And that's been published on by a number of authors ever since, with the potential for shorter recovery and no bridges burned. So again, we use the same setup, the same portals that we talked about earlier, traction on just the thumb. And again, you can see there's a lot of space. I typically recommend using fluoroscopy initially to make sure you're in the correct joint. It's not uncommon to find yourself in the STT joint accidentally. So make sure you're in the correct joint, the thumb CMC joint. And again, you'll see a lot of synovitis. Often you'll see loose bodies floating around in there, and you can excise those. And for early stage arthritis, in stage 1, in that young patient that's failed all conservative measures, I think this is a very good use of arthroscopy to use it to do a synovectomy, debride, and I like to use thermal shrinkage. I know it's somewhat controversial, but I do think it's very effective, not only in tightening the ligaments around the joint, but also to provide a denervation effect to the capsule as well. And so luckily, this is not a common situation, the young patient with early stage arthritis that does not respond to conservative measures. But in those rare situations where it does happen, I think this is a very nice treatment option. What about for the later stages? So Eaton stage 2 and 3, then you have more wear. And here I would recommend just inserting a burr, and just removing the distal 2 to 3 millimeters of the trapezium, just removing that bone-on-bone pain generator. Again, this is a 3.5 millimeter burr, so you can see there's plenty of space in this joint to maneuver. And that's pretty much it. It's quite easy. Here's a video showing very quickly the setup, the portals. You can see the 1U portal there directly ulnar to the EPB tendon, the 1R directly radial to the APL tendon. I like to draw the base of the thumb metacarpal, and you can see the portals, the little dots right above. And there's the thenar portal, about a centimeter or a centimeter and a half, and you triangulate to find that portal from the 1R portal. Once you establish your portals, you can see this is, again, a 3.5 millimeter shaver, so quite a large shaver, and you get that in there, and you just debride all the synovitis, debride any articular debris, and it really opens up your space and your view. And shortly, you'll see the metacarpal above and the trapezium below, and you can see there's plenty of space in here. Don't be intimidated by the thumb. There's the metacarpal above and the trapezium below. One little trick here is when you start resecting your bone, I like to use a smaller burr in a larger sheath. In other words, that's a 2.9 millimeter burr and a 3.5 millimeter burr. So I take the 2.9 millimeter inner burr, slide it into the 3.5 millimeter sheath. And what that does is it gives you much more room in your sheath for egress of bone and debris. Because sometimes when you start resecting bone, and whether that be any other bone resection arthroscopically, it gets clogged and it can be very frustrating. And so just use a smaller burr and a larger sleeve, and you won't have that clogging problem. And again, it's not rocket science. It's not difficult. You just remove the distal 2 millimeters of the trapezium. Do it under fluoroscopic guidance to make sure that you've taken enough. And in the past, I used to pin the CMC joint, allow the hematoma to form. The pin would stay in there for about 4 weeks. And then I would cast the patient for 4 weeks, remove the pins at 4 weeks, and then start therapy. And republished on our cohort of patients with a major benefit of having very little pain after a few days. There's no capsular dissection. And so these patients recover much faster, and there's no bridges burned. And their outcomes are very similar to what we would see with our open treatments. But as we all know, anytime there are pins involved, there can be pin complications, infections, irritation, etc. And so that led me down the road of using a suture button construct as a way of suspending the thumb in lieu of using external pins. And you can see without the suspension at time 0, you could see there's complete subsidence when you load the thumb after your hemitrapeziectomy. But with the suture button suspension, you could see immediate stability of your construct. And we wanted to confirm this with a biomechanical study. We showed that using this pinch protocol over 10,000 pinch cycles compared to a K-wire, the suture button was comparable in terms of subsidence. We also showed it to be safe to insert, with the closest nervascular structure being the nerve to the first dorsal interosseous muscle over a centimeter away, regardless of which trajectory you place the implant. It's relatively controversial. Some people feel strongly about placing it into the base. Some people feel strongly about placing it into the shaft of the second metacarpal. I don't think it really much matters based on our study here. And again, we described this technique about a decade ago. Here's a typical patient. Hemitrapeziectomy is seen here. And there you go with the hemitrapezium removed at time 0. I inserted the guide wire from the thumb metacarpal to the second metacarpal, pass the suture button from one to the other through a small incision. I think the pearl is to make sure that you check your range of motion on the table, your radial and palmar abduction, opposition, and circumduction. Make sure that it's not too tight. Tie provisional knots, check it, and then have your final knot security. And there again, final radiograph and the videos showing the suspension at time 0. The benefit here is that we immobilize our patients for only about 5 days because we have no external hardware. We start therapy at 5 days, and that really accelerates their range of motion. And we published our midterm clinical experience, mean follow-up of 64 months, and you can see their outcomes are certainly very good, not necessarily any better than any open techniques, but quite good with low morbidity. And we're now publishing our minimum 10-year follow-up. So it, again, shows not only that is it effective, but it's also durable out to 10 years. So to conclude, I think thumb CMCR arthroscopy is very useful, certainly for the treatment of Bennett or arthroscopic assisted treatment of Bennett's fractures, and also an effective option for thumb CMC arthritis. For me, the workhorse or the sweet spot is for Eaton stage 1 and 2. For stage, you can do it for stage 3 and 4 as well. It is a little bit more time consuming. You can remove the complete trapezium arthroscopically. But in those settings, for me, it's I still perform an open trapeziectomy. But for certainly earlier stages, it's very effective, coupled with the suspension plus or minus interposition if you believe in that. So with that, I'd like to thank you for your attention. Thank you again for the kind invitation to participate. And here's my email address in case anyone has any questions. Thanks again, Harvey and Andrew.
Thanks, Jeff. Wonderful presentation on the thumb CMCG arthroscopy. We'd like to move on to the next speaker, Professor Greg Bain from Adelaide, Australia. He's the second president of APWA. He's also very passionate about teaching and has been involved in numerous wrist and upper limb related courses worldwide as faculty and speaker. Today is no exception, except that he is unable to join us in Zoom because he's actually 40,000 feet in the air, going home to Adelaide from Madrid wrist course that just ended. So he has kindly pre-recorded his talk entitled The Future of Wrist Arthroscopy to contribute his work in improving the training of future arthroscopy courses and for better patient care. Could the admin team please play the pre-recorded lecture by Professor Greg Bain? Thank you. I can't hear the recording. Could you turn the volume up?
Sorry, were you able to hear it?
No, we cannot hear it.
No, we can't hear.
Are you able to hear it now?
Nope.
No. Let me try playing it again on mine.
Okay.
It's a great pleasure to be involved in this symposium.
Can everybody hear?
I regret that I'm not there with you today. This presentation is on the future of wrist arthroscopy. It's Greg Bain speaking. These are my conflicts of interest. This is clearly relevant with regard to FuseTech, who are a company that manufacture the advanced surgical training models in Adelaide. I've also provided paid presentations for these two companies. The models that I'm going to demonstrate are examples on the left of the wrist, the hand, and the more recent one, which is the example where you can see the clear skin, so you can see some of the deeper anatomical structures, which we think is of value, particularly for the junior surgeons. The image on your top left is a photograph of one of the models, and we can see an X-ray of the model, CT scan, and fluoroscopy. All of these imaging modalities are actually of the model, not of the human hand. The 3D CT scan on the left demonstrates the distal radius and the carpus in the model, and we can see all the ligament attachments. This individual model has a distal radius fracture, scaphoid fracture, TFC tear, and scapular instability. We can see that this example shows the dorsal capsule with the associated ligament complex. This is an arthroscopy of one of the models. A diagnostic arthroscopy is being performed. We can see a distal radius fracture in the foreground here. And as we pass up through the drive-through sign between the scaphoid and the lunate, we go to the mid-carpal joint. And we can see across to the lunate and to the triquetrum. So one of the things about the models, I think, particularly for the junior doctors, it helps give them an understanding of the three-dimensional spatial awareness within the wrist, to be able to practice some of the concepts of the box, to be able to put the articulation in the correct position, and to ensure that the working instruments are identified and used in the appropriate way. So it really does, I think, particularly in the junior doctors, enable them to get to the point where they can perform standard arthroscopy. This demonstrates here one of the needle scopes, which enables us to again use this sort of scope in that one of the models. We can see the scapular ligament there, distal radius fracture, and we're able to manipulate the wrist to enable the fracture to open up.
In this example, we've got a K-wire, which we've just advanced straight through the skin. We place this into the radial styloid. Just using a drill, which we bought from a hardware store, we're able to advance the K-wires into the distal radius. We can see that we don't need to wear gloves, and we can manipulate the distal radius fracture with these K-wires and ensure that an appropriate reduction is achieved. We can also link this with open surgery for the distal radius. So we expose the viral aspect of the distal radius and the associated soft tissue structures are identified and dissected out. We can see that the fracture of the distal radius can be seen. And in this particular example, we would need to cut the periosteum to allow the displaced fracture of the distal radius to be identified. On the right, we can see the example of using one of the arthroscopes and also using fluoroscopy to assess the position of the fracture reduction. So using this combination of the surgical models, fluoroscopy, arthroscopy, we found that to be a very useful training model to understand how to manipulate, stabilize distal radius fractures and also associated carpal injuries. Going on now to looking at the foveal tears from the distal foveal attachment onto the ulna. We can see in this particular example, the triangular fibrocartilage can be assessed and a scope can be introduced into the sigmoid notch. So we can see the sigmoid notch, it looks really very realistic, and we can see the undersurface of triangular fibrocartilage and the associated foveal attachment of the TFC. In this particular example, we're looking into the distal radial ulnar joint. We can elevate the triangular fibrocartilage off of the fovea to expose the head of the ulna and also then advance the wires and practice the concepts of the surgical repairs. This can be either as an outside-in or an inside-out surgical procedure. So in this case, a Thales needle is being advanced through the TFC, through the ulnar side of the wrist, and this can be then repositioned and the mattress sutures can then be tied on the ulnar aspect of the wrist. In this particular example, an outside-in technique is used. The needles are passed through and the sutures are then grasped to enable a mattress suture on the ulnar side. We've also been able to use the models in training for surgical techniques which are ultrasound guided. The models are designed to be able to be used with ultrasound as well. And so we can see here the local anesthetic being infiltrated into the model on the undersurface of the flexor retinaculum. And with this spiral cut technique, the undersurface of the flexor retinaculum is divided, and this enables the surgeon to be able to practice in this safe environment how to perform this type of surgery. So advanced manufacturing through the surgical training models, well, they're safe. They don't have any of the concerns of cadavers. All of the students in the room have the same model, so it enables us to do pathology on demand, so we can start with simple things and go to more complex fractures. An example on the right with a malunion of the distal radius, this could be used to enable us to practice these type of more complex things. So it enables us to control the learning curve. So I think the future of surgical training is to be able to bring the training models and the surgical training to the doctors, to enable the doctors to be able to perform the training in their time. It'll be anytime, anywhere, and any pathology. So like there's one of these young lady doctors, and she's able to continue on with her family commitments, but yet continue to train and learn. She probably wouldn't have her son in the cadaveric lab. So I think the models are fit for purpose. They are able to demonstrate the associated pathology and soft tissue attachments. The haptic X-ray and the no need for PPE, I think, really makes it a little bit easier. So we often have a coffee or even some food when we're actually performing the surgical procedures. So also the models, they're trying to go green as best they can. We don't need to use PPE. They're associated restricted cassettes that can be used, and so they would be disposed of. We're able to add super glue to them to be able to repair them, and the materials are being recycled, and we don't need to do things like use autoclaves. So we're quite keen on developing more complex courses, such as, for example, in this case, with a perilunate dislocation, to be able to have all senior surgeons in the room and to be able to perform the stabilisation of these complex injuries with arthroscopy or open techniques and learn from each other. So I think it is time to look at switching on the light to be able to get a different perspective on surgical training. It also enables that surgical training can be done at home in the surgeon's time, such as using one of these arthroscopes that you purchased and just plug straight into your computer. So the learning environment has changed. It becomes much more collegial and it's much more fun. It's much more relaxed, and we can do it more often because of the availability. So I think there's going to be a real change in surgical training, and I think this can be done in a safe way so that we can all learn how to more reliably and reproducibly be able to perform the technical aspects of surgery. Thank you very much.
Well, thank you very much for a wonderful talk by Greg Bain. I think time is not really on our side. We only have about 3 minutes before the magical time of 9:30 US, the Eastern time, will then force us to end this webinar. So are there any questions from the floor? I think there's quite a bit of buzz over the chat, and certainly there are quite a few good questions that have been shared. Is PC, are you around, PC? PC, there's one question. Have you ever continued doing open surgery for scaphoid, non-union and malunion, despite the fact you have done so many of the arthroscopic, done a lot of cases arthroscopically? Are there instances where you still have to do the open technique?
Actually, not in the last 20 years. So,
okay, so
I
you're
remember
totally exclusively arthroscopic, huh?
Only one case with failed APG, we tried using the vascular medial femoral condyle bone graft, which worked actually. But I think most of the time, actually, now if I encounter a revision case, I will repeat APG one more time. And in fact, all my last 6 cases in my series of initial failure all heal after the second APG. So for this reason, I really had to find any reason to do open surgery.
Right, thank you.
Andrew, that's a really interesting point. I want to, if I may, I just want to ask the speakers quickly as well, since everybody is such an expert in wrist arthroscopy, are there any indications that you would do open surgery? Like Sanj, will you do any SL repairs open? Jeff, would you do any, Jeffrey, would you do any like distal radius ORF, like without arthroscopy? I'd love to hear your thoughts on that.
Yeah, I think, Harvey, great question. I think for me, for SL now, I try and do everything through the scope, but there are cases, if I can't get the satisfactory reduction, then I will convert to an open scapholunate ligament reconstruction. But it's I haven't done that in the last several years.
How about you, Jeffrey? Would you do you use arthroscopy for all your distal radius?
Jeffrey, unmute yourself, Jeffrey. Unmute, Jeffrey.
Yep. Thank you. So usually right, for this half, I think it is about 10 years, I haven't seen a type A distal radius fracture in my hand, because all the type A AO type A distal radius fracture goes to my trainee and let them have training. So I think the only indication that I don't use the wrist arthroscopy is the type A AO type A distal radius fracture, and without any suspicions of intra-articular soft tissue injuries.
Thank you. And Jeff Yao, I was wondering, do you ever do like an open trapeziectomy anymore? Everything is just arthroscopic like everybody else.
No, actually, I would say that I do use open surgery a lot for Eaton stage 3 and 4. Those are the more common patients, right? The older patient with more advanced CMC disease. So I will still do that open, mostly because to remove it open takes 1 minute, not 1 minute, but very it's done very quickly. Open versus the arthroscopic management does take a little bit more time, and so I reserve that for the younger patient, particularly with early stage disease, so Eaton stage 1 or stage 2.
And I also see Professors Nakamura and Professors Bain are with us. Would you like to make any comments on this point?
Yeah, I think one of the points is that it's a progression as we all evolve.
In my hospital, we do a lot of these things arthroscopically, but there are times where time constraints and also the opportunity for training of junior doctors that these things are still done as an open procedure. So we're certainly moving towards trying to do most of these things as an arthroscopic technique.
Thank you. Professor Nakamura?
Yeah, sorry for that.
I was wondering if you do, to follow at that point, do you still do any open surgery for the TFCC or DRUJ, or everything is totally arthroscopic?
Yeah, if I found that the ligament cannot be repaired, so that we actually have so many scar formation as a foveal region, then I do open.
Great, thank you so much. Andrew, do you have any other questions we think we should ask? We should cover?
Yeah, can I ask Greg Bain, how close or how near do you see this these models being implemented for future risk courses? Is it very soon, or we can just totally displace the cadaveric workshops?
So we're currently using the models. They're available now. I don't own the models, but I do have an association with them. So FuseTech is the company in Adelaide. If you contact me or them, I'm sure that they can provide the risk models for you. The current risk models have a fracture of the distal radius, scapholunate instability, scaphoid fracture. So in TFC test, I think it's a good model for wrist arthroscopy, and so I think we can use that in our courses. And I really think that's where we're going to go because of some of the cost issues, some of the logistics of organising the courses with cadavers.
That is good because you don't have to do it in a lab, right? You can actually do it in a hotel or something like that because these are all the.
Well, the other thing I think is going to happen is you can do it at home. So if you were a trainee, to be able to buy your own wrist scope and to be able to practice doing scaphoid fractures or scapholunate instabilities in your time, so that you can sort of do it every day for a while, so that you get used to being able to manage the instruments and understanding the three-dimensional anatomy. I think that would be very valuable. So during my training, I often found that I would do a technique, and then I wouldn't be able to actually, you don't get to practice it as much as you'd like. So this really opens up the training opportunities.
Right. Thanks so much. Yeah, Harvey, I think that's probably about it. I think we're definitely over time.
Yeah. So in the interest of time, we're going to end this a bit earlier. If there are any other questions from the audience, please feel free to email the speakers directly or contact them. And I want to thank everybody again for really taking the time to talk to us on a Saturday. This was such an excellent webinar. I learned so much myself. I'm sure everybody did as well. I'm going to turn this over to Sonu for some final concluding remarks. And again, from me and Andrew Chin, thank you so much, everybody, for taking the time to talk to all of us and teach us.
Thanks, Harvey. I'd like to really thank our moderators, Harvey and Andrew, and to all of our real world-renowned speakers for a tour de force of a webinar. I learned so much from all of you. And special thanks to the Asia Pacific Wrist Association for the collaboration on this webinar. And I'd like to thank you, the audience, for spending your day or night, depending where you are with us, and invite you to join us for upcoming webinars in our hand-in-hand webinar series, which can be located at the AAHS website at handsurgery.org. Good day and good night.
Everyone should put their camera on. Put your camera on.
Yeah, everybody can put their camera on.
Yeah. Yes, I can't get my camera on. Can somebody open up my video? Yes.
Oh yeah, we'll have the speakers stay on for a group photo. So PC, you want everybody to hold the hand up, or what do you want?
Okay, yeah, very good. Okay.
All right, sure.
Someone take a photo for us. Thank you. Is somebody take a photo?
I got it.
I got no hand up. Thank you. Please share the photo.
Of course. All right.
Thank you.
Well, thank you so much, everybody. Hope to see you all again soon. Have a good weekend.
Everyone.
Take care.
Bye.
Good night.
Bye. Good night.
Good night.
Bye-bye.
Good night or good day.
Yes.
Good night.